Welcome to our channel, viewers. This video tutorial is about management of locally advanced gallbladder cancer. So friends, as far as early gallbladder cancer is concerned, there is no controversy about the management, that it is straightforward. Extended or radical cholecystectomy, that is the straightforward surgery, is the answer, and that is curative approach. But when we encounter a patient of locally advanced gallbladder cancer, there are many controversies, there are many issues, and so with this video tutorial, we'll try to answer all the controversies like the role of staging laparoscopy, PET scan, the early neoadjuvant chemotherapy, the extent of resection like HPD in gallbladder cancer, so that we can give viewers a scientific rationale based on the current literature evidence to the approach of locally advanced gallbladder cancer. So we have divided this video in two parts to keep the video length short, otherwise you will get bored. So in the first part, we will cover the definition of locally advanced gallbladder cancer, the anatomy, lymphatics, the TNM, the latest AJCC edition, what are surgical options, then the staging laparoscopy and jaundice in gallbladder cancer. The second part will be multivisceral resection in gallbladder cancer, then the papillary variant, then PET-CT and research gap in gallbladder cancer. So these first four lines, these are the four issues that we will cover in the first part, and 5, 6, 7, 8 will be covered in the second part. And friends, the second video will be available for free exclusively on our app. So please don't forget to get connected with us on our app or on the website. So friends, in the gallbladder cancer management, we have already uploaded three lengthy videos, I will say, in which we have discussed the basically live surgery with brief theoretical discussion, and this video is only theoretical discussion. So we have covered in detail about the lymphadenectomy, the staging laparoscopy, then the aortocaval lymph node sampling, then all the steps of hepatic bed resection. These steps are already covered. If you have not watched our previous videos, please do watch those videos, and you will get better understanding about the radical or extended cholecystectomy in gallbladder cancer. We have applied some filter on these pics, otherwise all these pics and surgical videos goes against the community guidelines, but full HD video and premium quality content is available in the members only section and on our app. So please don't forget to check out these links. You can scan this QR code to visit our official website, and if you are using the iOS, then please don't forget to use the code NJOFT as written here. And you can scan this QR code if you want to view the content on YouTube only. Then this is the for members only section, and there are around 19 videos and of premium HD quality available in members only section. So please do visit these links. So friends, the gallbladder cancer is staged according to the depth of invasion of GB ball and the extent of spread to the surrounding structures and lymph nodes. So the invasion of the hilar structure, that will be CVD, hepatic artery, portal vein, usually render the tumor locally unresectable, or that will require a major surgery. And there is one peculiarity about the GB is that there is no submucosa. I don't think there is any other organ in human body which lacks the submucosa, that is hollow viscous organ which lack the submucosa. And if there is any, please do update me in the comment section. The peculiarity about the GB is that it is partly intraperitoneal, that is the serosa is lacking on the one side, and it is embedded the GB. And the 5-year survival, it's 80 to 100% for T1 T2 after the resection, but it goes down to 10 to 30% for locally advanced tumors, that is T3 T4 tumors. Friends, all these figures and facts are based on the literature review, and I have given the relevant reference here also. So viewers can check these references for more in-depth analysis of the facts and figures. So as I said earlier, it is partially intraperitoneal structure and it lacks serosa toward the liver side, and it is separated from the liver by the thin fibrous plate, that is a cystic plate. Friends, when we inject a dye into the GB lymphatics, there is no proximal migration. So there is generally a orderly migration of this dye, that is lymphatics, from the GB lymphatic firstly to cystic and pericoldocal. There you can see the curved arrows, From there to retroportal and posterior superior pancreaticoduodenal nodes. Then the celiac and superior mesenteric and interaortocaval lymph nodes. But sometime, as you can see from the pericortical lymph nodes, the direct arrow which can goes directly to the interaortocaval lymph nodes. So that's why sometimes they are skip metastasis, and there is a directly involvement of the aortocaval lymph nodes. And friends, the involvement of aortocaval lymph nodes makes it a M1 disease. So that is the importance, and if we will discuss it more later on also. And please do watch our previous surgery videos if you have not watched those videos, to have better understanding of the concept. So these are some of the figures that you may need to remember for your examination purpose, for super specialty examination, so that the relative incidence of regional invasion and metastasis diagnosis, 10% are confined to gallbladder, liver invasion is seen 59%, common bile duct infiltration 35%, portal vein hepatic artery invasion 15%. So different series, this is the rate. And you have to understand that it only confined to the gallbladder will be only 10%, and other will have other invasion of structure like liver, common bile duct, lymphatic or liver mets. So briefly we will discuss about the AJCC staging, that is according to the 8th edition, and also we will try to demonstrate the difference between 8th and 7th. So friends, T1 is when tumor invades the lamina propria or muscular layer. Just remember, for any other organ, especially the hollow viscous organ, T2 is involvement of the muscle layer. But as I said, there is no submucosal layer in gallbladder. So T1B, which would be an early stage in other organs because there is submucosa, and it is all the submucosal involvement, that will be T1 or T1B. But here, as there is no submucosa, so the involvement of the muscle layer is T1B. So T1A is the lamina propria, that's the basement membrane. T1B is when it involves the muscle layer of the GB. T2 is when it goes beyond the muscle layer, that is perimuscular connective tissue on peritoneal side, or without involvement of the serosa, or tumor invades perimuscular connective tissue on hepatic side with no extension into the liver. So T2 is still confined to the gallbladder. And then T2 is divided to A and B. T1 is A and B, T2 is A and B. And just remember, A is, for the sake of remembering, A is interior and B is back, so back towards the liver side, and B is also bad. So T2 is A is tumor invades perimuscular connective tissue on peritoneal side, but there is no involvement of serosa. Serosa is intact. And T2B is tumor invades the perimuscular connective tissue on hepatic side with no extension into the liver. So perimuscular connective tissue, that it has already breached the cystic plate, but there is no involvement of liver, and so serosal surface is lacking. So any tumor which is invading towards the liver, that is T2B, has a bad prognosis, and that's the reason that simple cholecystectomy is not sufficient for any tumor in which we find the tumor later on after the cholecystectomy. So we need a extra surgery, that will be completion extended cholecystectomy after incidental CHGB. T3 will be when it perforates the serosa towards the peritoneal side, the serosal perforation is T3, or it directly invades the liver and or one other adjacent organ. That means the involvement of liver or liver plus one extra organ to the liver, or any extra organ except the liver, will be T3. When it involves two or more extrahepatic organs, then will be T4, or involvement of the main portal vein hepatic artery also makes it T4. So direct tumor extension into a liver is not considered metastatic. As I said, that it is a direct involvement, that will make it T3 only. Direct invasion of other adjacent organs including colon, duodenum, stomach, CVD, abdominal wall or diaphragm is not considered distant metastasis. Just remember these things. So two or more organs are involved, like it is infiltrating into the liver, it is infiltrating into the stomach, it is infiltrating into the duodenum or the colon. It is still T4 because that will be considered as a local invasion, not a metastatic disease. So friends, coming to the regional lymph nodes. So the regional lymph nodes are along the CVT, hepatic artery, portal vein and cystic duct. So that will be mainly station 12 lymph nodes and station 8 lymph nodes. That is all the lymph nodes toward the right of the celiac trunk, and we have already made a detailed video on the lymph node station. Lymph node station are common for the gastric cancer, for the gallbladder cancer, or for the esophagus. And please you have a look in our gastric cancer series, so you will have better understanding of the lymph node station. So friends, there is one controversy in AJCC 8 and 7. So AJCC 7th edition, there N1 was when metastasis was to the regional lymph node, that is cystic duct, CBD, hepatic artery and portal vein. And N2 was metastasis to periaortic, pericable, SMA or celiac axis lymph nodes. So N2 is like a disease that is locally advanced. But in 8th edition, they have given N1 and N2 as a number. So metastasis to 1 to 3 is N1 and 4 or more is like N2. So I mean, this is one controversy for which I could not find a relevant answer or a good answer, because if you find 4 lymph nodes and that were perigoldical only, but then again pathologically it will be labeled as N2. But for the time being, just remember that based upon 8th edition, it is 1 to 3 is N1 and N2 is 4 or more. And but as per the 7th, N1 was regional and N2 was extra regional lymph nodes. And if we find some suitable answer, we will update our viewers in due time. Friends, any tumor with N2 stage or any tumor that is like any for that matter, any tumor with lymph node metastasis will be locally advanced. So T3 T4 tumor with N1 staging is locally advanced, or any N2 tumor with lymph node in 4 or more or extra regional lymph nodes will be considered as locally advanced. So just remember this combination, and you will be able to answer many questions in your super specialty examination. So patient with lymph node metastasis, that is stage 3B or higher, are locally advanced tumors, and stage 4A or higher rarely experience long-term survival. Coming to the surgical approach in gallbladder cancer. So arterial resection is only curative treatment at present time. There is no other option. If patient is resectable, he or she should be resected. The optimal resection consists of cholecystectomy with hepatic budget resection and portal lymphadenectomy. Lymphadenectomy in porta hepatis, gastrohepatic ligament, retroduodenal. That is, the regional lymph nodes are taken out, and we always sample the aortocable lymph node before proceeding for the major surgery. Extended hepatic or bile duct resection may be necessary, and that we will cover in multivisceral resection, the rationale, the benefits, and the disadvantage of that. So this picture is from Memorial Sloan Kettering paper, and all the area which is highlighted in pink color has to be cleared as a part of a radical extended cholecystectomy. We have made a detailed video demonstration of the surgery in 3 parts. Do check those videos and you will have better in-depth knowledge of the this procedure. Another controversy that you will hear in many of the surgical conferences or talks is that should we do a wedge resection or should we do an anatomical wedge resection, that is segment 4B and 5. So this is an important paper by Chancy et al. So in this paper, they analyze 134 patients with curative intersection, and out of which T3 gallbladder cancer patient 57 had wedge resection and 37 had anatomical segment 4B and 5 section. So for T3 stage cancer, neither segmentectomy or anatomical section nor CVD section improve the prognosis. That means the 1-3-5 year survival, overall survival was 71, 70 and 64 for wedge, and 67, 56 and 56.8 for anatomical 4B and 5 section, which was not statistically significant. So friends, the answer to this controversy is it doesn't make difference either you are doing segmental resection, that is 4B5 anatomical wedge resection, or the non-anatomical, simple 2-3 centimeter liver wedge. The outcome was similar. So if we don't have any other evidence, then we have to rely on this evidence only. Another interesting field or the controversy in gallbladder cancer will be patient presenting with a jaundice for gallbladder cancer. So friends, 30 to 50% of the patient with gallbladder cancer will present with jaundice, and the jaundice in gallbladder cancer can be due to the concomitant CVD stone. It can be tumor thrombus in a papillary variant, or mostly it is by the obstruction by lymph node at the porta, or it can be because of direct tumor extension into the CVD when it is involving the neck of the gallbladder. Hawkins et al. Reported that approximately 34% of the localized gallbladder cancer presented with jaundice. So the patient of gallbladder cancer presenting with a jaundice is relatively higher incidence. And one of the series, this was one of the first series which reported the outcome. So only 6, that is 7%, were resectable, and all 6 patients experienced or died of disease within 2 years. That means the prognosis of patient with jaundice, if it is because of the gallbladder cancer, direct extension or tumor load or the lymph node mets, is dismal, and the overall median survival is roughly less than 6 months. So this is another side of the picture, that is when patient in this paper by Ragimebu et al. They analyze their data for the last 10 years, and they try to prognosticate the value of jaundice related to morbidity, mortality and survival. So out of 429 patients, 110 gallbladder cancer presented with jaundice, and out of which only 50, that is 45%, were resectable. The post-operative mortality and morbidity rate was higher, that was 16% mortality and 62% morbidity, which is quite significant. And only out of which, that is 50 resected out of this 110, 71% had R0 resection and 46% had pathological lymph node involvement. So for the 50 patients resected, the 1 and 3 years survival was 48% and 19%, but it was still better as compared to the patient non-resected. That's roughly 60 patients who were not resected. They have only 31% 1 year survival and 0% survival after 3 years, which was statistically significant. So that means if we can resect the patient with jaundice, then we should give a reasonable, because that is the only curative or only hope for long-term survival. But remembering that these patients have poor overall survival and higher mortality and morbidity, that needs to be explained to the patient. So this is the data from the same paper. So the resectability rate was significantly lower in the jaundice patient, and it required major surgery like major hepatectomy, which was significant. Again, portable resection, arterial resection, common bile duct resection. So if we interpret this data, that means these patients require a major surgery that may involve major hepatectomy, more than 3 segments, or arterial and vein resection, and so that leads increase the mortality morbidity. But when resected, the overall survival is better if not resected. So this series confirmed that jaundice is a poor prognostic factor, but however the jaundice does not preclude resection, especially when we have a proper patient selection. And again, another drawback of this paper or this series was that they didn't do routine iotogammal lymph node sampling, which is must, and in the present era it's not possible to proceed for major surgery in GBC without intra-iotogammal lymph node sampling. That means some of the metastatic patients might have undergone resection in this series. So another issue or controversy will be, should we do staging laparoscopy in all the gallbladder cancer, or should we proceed with the surgical resection straightforward? This is a landmark paper by Agrawal, AK et al. And this was a prospective study in which they analyzed the gallbladder cancer patient considered resectable based upon the preoperative imaging. So total 98 patients with incidental gallbladder cancer, they were excluded in this series. and they showed that there was higher yield in locally advanced tumor compared with the early stage. That is, the yield of staging laparoscopy detecting mets was higher when the patient had a locally advanced gallbladder tumor, that was 25 versus 10%, which was significant finding. The accuracy of detecting unresectable disease and a detectable lesion in locally advanced tumor is 56% versus 94%. And so staging laparoscopy obviated the need for laparotomy in 55.9% of patients with unresectable disease, and that is a very significant number. In a head-to-head comparison between early gallbladder cancer and locally advanced gallbladder cancer, the yield of staging laparoscopy, as highlighted, was 10.7% in early and 25.21% in locally advanced gallbladder cancer, and it is a statistically significant number. So, having said so, that means if we can avoid so many laparotomy by simply putting a laparoscope, so it would be a criminal, as one of my teachers used to say, it would be criminal to proceed for a surgery in gallbladder cancer without doing a staging laparoscopy. So just remember, always put the laparoscope before proceeding for surgery in any case of gallbladder cancer, and you may obviate the need of formal laparotomy in many. So friends, we are concluding the first part here, the multivisceral resection, the papillary variant of gallbladder cancer, the role of adjuvant therapy and research gap in gallbladder cancer. We will answer in the second part of this video. So as a part of promotion to our app or our small startup, we will upload the second part exclusively on our app. So please don't forget to get connected with us, and to get connected you can scan these codes or visit the link which we have provided in the description of this video. And some of these videos are available for free as a bonus, as a part of promotion. Or if you want to visit watch these videos only on YouTube, then you can join our channel membership, and the link for same is also available in description. Or you can scan these codes, and if you are using the Apple or iOS platform, then put this organization code, or code will be NJOFT, just remember. And so thanks for watching, viewers. And if you're watching this video on YouTube, then don't forget to like the content and subscribe to the channel. Hit the bell icon for all the future updates. So thank you very much. Happy learning.